So you can use this,
Yes.
or you can use these.
And is there a pointer somewhere?
Maybe.
No, I like to use this so I can point on the stuff here.
Okay.
Let me show.
Yeah, so you should be good.
Okay.
Is my stuff in your way? Or can this stay here?
No, as long as yeah, sure. That can totally stay here. Maybe
Okay.
a water, because I don't mix it up.
I will take my water.
I don't mix it up.
All right, I will introduce you, and then thank you so much for hopping up earlier.
Oh, yeah.
Like I think it was really. This is the my third, fourth conference. I don't know, but having you up here was great because a lot of the questions really.
Yeah, rheumatology.
I mean,
no, that's I kind of thought I should come earlier.
it's great.
Good. I'm glad it worked out.
I'm booking you for the next one.
We'll wait for this. We'll wait.
I did see your slide presentation. It is very comprehensive. I'm a little worried on time.
And I totally changed it last time.
Okay, good. So it's not 70 slides.
It might be, but don't worry at all.
Okay.
I'll be done.
I was at a
I'm just
Tuesday.
going to be speaking. I'm going to be highlighting because they have the hand. I'm going to be just saying this is the main point of this.
Okay.
That's it. You'll be fine.
Okay.
Yeah,
And I want to make sure that we have time for questions
Hey,
for the
I'll give you
for the
15
people.
minutes. Yeah.
Okay.
I'll finish early.
Okay. Fabulous.
Alrighty.
Come on in. Come on in.
Are we done?
It's around. Just walk around and just keep walking. It's across from the vending machines. How's it going? Do you like it? And you're learning something? You learning something? It's like a foundation. It's basically this contraction of the two hooks on either side. Kind of like helps you get things on, like folders. So like if you put it bend, there's almost like you can sort of like pull something up. Not so much. I understand. I just went back to hot yoga. What I like about it once I feel like I'm not going back is that it does help with the joints and stretching muscles a little faster. What I think told you that you can be careful because in that heat you can overextend and stretch farther. I feel like for hot yoga you kind of need to practice the skill regularly because your body it's hard for your body to react to that heat. We gotta start. Okay, we're gonna start. Whether their people are in their seats or not. Welcome back. I hope you guys are liking the presentation so far. I know I am. So Dr. Swami Venutrupalli has already been up here, so you've already sort of met him. But I'm going to tell you a little bit about him. He's got a long name, so often people call him Dr. V. And Dr. V is the clinical chief of rheumatology at Cedars-Sinai Medical Center and the co-chair of the Lupus LA Board, Medical Advisory Board. So he's a busy guy. And he's one of the country's leading research investigators for lupus, rheumatoid arthritis, inflammatory muscle disease, and Sjogren's. He's involved in over 100 clinical trials at Cedars, and his current research focuses on the use of technology to solve healthcare problems. I know he's going to talk a little bit about that today. When he's not seeing patients in his practice or working on a new research project or sleeping, he teaches at UCLA and is a key faculty member of the Rheumatology Fellowship Program at Cedars-Sinai. Dr. V is a highly regarded clinician by both colleagues and patients for his outstanding service and expertise. Please welcome Dr. Venutrupalli.
Thank you. Right. Let me... how are we doing on the mic volume in the back? Is this good? No? Louder? Yeah, I don't think that... Is this on? Yeah, we're good? All right, so I speak louder. I need a mouse.
It's right here. I'm going to take all this out of your way.
Thank you. All right. Is this good? Can you hear me now? Okay. So thank you so much, Toby, for the introduction. I appreciate it. Thank you, Lupus LA, for inviting me, and thank you to all of you for coming here on a Saturday to learn about lupus. I was asked to do the keynote lecture today. Generally, my partner, Dr. Wallace, does it. He does a great job. He's a legend in the field of lupus. A lot of you know him. Big shoes to fill, and I'm happy to be here and spend some time with you guys, share what my insights and knowledge are on this field. Okay, so I'm going to give you an overview of what I'm going to be speaking about. What is lupus? I understand that this is the latest in lupus talk, but I'm always asked the same questions when I finish that talk. What about the basics? So I'm going to spend a few minutes on the basics. I'm going to talk to you about who's at risk for what, and then we're going to talk about the biologic revolution. Have we done anything with the biologic revolution? Have we cured lupus? The answer is obvious, no, but what's the reason for that? Are there any silver linings in the data that we now have available to us? And lastly, I'm going to talk about what I look at and I feel great about, and I see hope. I want to share that with you because I'm really enthusiastic about what what the upcoming years are going to bring for all of us. Okay? So, lupus basically affects women, primarily 90%. It seems to affect certain ethnic groups worse than others. Native Americans, African Americans, Asians of certain types, and Latinos primarily seem to get it a little worse. And the prevalence estimates in the United States vary depending on who you ask, between 200,000 people to 2 million people. And that includes all comers. When you think of 2 million, you think of people who may or may not have full-blown lupus. Okay? Their types of lupus are cutaneous, that's limited only to the skin. And the good news here is that 95% of people who have cutaneous lupus do not progress to systemic lupus, 90 to 95%. So if you just have cutaneous, that's a good thing. It's not systemic. In systemic, we have two different types, organ-threatening and non-organ-threatening. And if you have non-organ-threatening disease, it's generally a better prognosis than people who have organ-threatening disease. Drug-induced lupus, there are a lot of drugs that we use, medications that can actually induce lupus. And then there's overlaps with other autoimmune diseases. For example, you can have lupus overlapping with scleroderma. Also, as we go on with this talk, I apologize, but I wasn't thrilled with the talk in the shape and form it was in the handouts. So I've taken the liberty to change things to make it a little bit more fun for you and for me. Okay? So if you don't see the slides here, don't get exasperated. We're going to put this talk up online. So just, Google Dr. Swami lupus and you'll find it probably in a day or two. Okay? And we'll have the audio and everything. So just listen, take the key points. I'm going to focus on the key messages for each slide. And if you want to look at the details, you have it in your handout. Okay? So one thing that's new, kind of new in lupus, is that we've used criteria to diagnose lupus since the 1980s. They're called the American College of Rheumatology criteria. And based on those criteria, if you met 4 out of the 11 criteria, you had lupus. And if you met 3, you did not have lupus. And then we had a lot of people who met 3, and they were like, what do I have? And, we couldn't really give them a diagnosis. So things have changed a little bit. We've made those criteria a little bit more user-friendly, a little bit more friendly to understand, to diagnose people earlier. Okay, that's our whole goal, to really diagnose people and to modify those criteria from the 1980s. We're in 2015. We got to do this. So anyway, we have this new criteria. The highlights of these new criteria are underlined in the slide. So firstly, if you have kidney disease from lupus, that's it. You're done. You have lupus. You meet criteria. In the old criteria, you still needed to meet 4 out of 11. So in this new iteration of the criteria, if you have kidney disease, that's it. You have lupus. Okay, you don't need to have any of the other things. Subacute cutaneous lupus, which is a type of rash which happens with sun exposure, is now part of the criteria. Also, non-scarring alopecia, which is basically hair loss in a diffuse manner, that's part of the new criteria. The neurological portion of the criteria have been expanded significantly, which is great. Previously in the criteria, all we could say was you only met the criteria if you had seizures or psychosis and nothing else, but doctor, my nerves are not working in my legs. I'm sorry, but, you don't meet criteria for lupus. Now we've expanded that, which is a great thing. We include people who have mononeuritis multiplex, which is a condition where certain nerves get damaged. Myelitis, which is spinal cord involvement in lupus. We're recognizing that does happen. Peripheral neuropathy, which is nerve damage distally in the extremities, and people who have that can now still meet criteria. So the other criteria are pretty similar to what they were before. And then immunological criteria. And now you need 1 from the previous group and 1 from this group at the very minimum. And then you need 2 other criteria, and then you can be diagnosed with lupus. Among the immunological criteria, the difference now is that antiphospholipid antibodies are recognized as being independent. Okay? So if you have antiphospholipid antibodies, and this was really underreported previously, but we find that about 30 to 40% of our lupus patients actually have antiphospholipid antibodies. And these antibodies are important because they predispose one to strokes, heart attacks, and clots. And it's really important to recognize that, and every patient with lupus should undergo evaluation for these antibodies. What's new is that these antibodies, in the absence of ANA even, and you can still meet criteria for lupus. Even if you have a borderline ANA, but if you have antiphospholipid antibodies, that counts as 2 criteria, borderline ANA and antiphospholipid. Complement levels, we've been using these to monitor lupus activity. That's one of our best tests we have for monitoring whether a patient's lupus is active or not. If your complements are low, that means disease generally is active. These made it into the criteria. And lastly, positive Coombs test. It's a type of test that indicates whether or not a red blood cell might get hemolyzed. That means that's in the criteria. I love this slide. I don't know if people love it as much as I do, but I always include it in my talks. This is how I think of the immune system. I'm going to try and share it with you and see how far we get. So what do we know of lupus? This is a great cartoon. It's a beautiful illustration of what we know. What is the current status of our knowledge? Okay. So what we know is that there's about 40 genes, that have been identified to be associated with lupus. And generally, these are genes that affect different parts of the immune system. So you need to have the genes, but only about 25% of lupus is attributable to the genes. So the rest, 75% of lupus causation, is not from genes. There's something else going on. And that's the environment. We lump it all together and say this is the environmental factor. So in the right person who's got the genetic background, there's something from the environment that happens and triggers lupus. Okay? We have some ideas of what these environmental triggers are. Okay? We don't know for sure, but we have studies that show that sun exposure is important. It might trigger lupus. Sun exposure causes cell death in the skin. And all the dead cells, they release DNA. Okay? DNA is released, and normally, if you had a normal immune system, the DNA can be cleared out and broken down by the factory in your liver into amino acids and can be made into new proteins. But in people who have abnormal genes of the immune system, they can't clear all that DNA that well. Okay? Some of the genes that have been implicated are IRF5 and STAT4, and these are immune genes, okay? And two main players are present here in the immune system, the plasmacytoid dendritic cell and the myeloid dendritic cell. Myeloid dendritic cells come from the bone marrow. These are in the plasma. And if you have these gene defects, and if you get exposed to DNA from dead cells, these toll-like receptors get stimulated, and they get overstimulated. And what happens is that these cells pour out something called interferon alpha. Interferon alpha has now been shown to be able to actually give a signature pattern. This is called the interferon alpha signature of lupus. So if we took a patient with lupus, and if we tested their genes, we could see all the genes associated with interferon alpha signaling go crazy, go really high, okay? And then we treat the patient, those interferon alpha signature goes down, okay? This is not available in routine clinical practice today, but in a few years it might be. We'll be able to look at gene signatures and say, okay, this person's flaring, this person's not, this person looks like their kidney's at risk, this person looks like their heart is at risk. So we'll get there. We're not there yet. So there's two types of immune system reactions. The first is called the innate immune or the immediate defense system. Okay, the innate immune system, the plasmacytoid dendritic cells get stimulated, throw out tons of interferon alpha, which recruits neutrophils or white cells and macrophages, and these go into the blood vessels of the organs. Okay? The tiny blood vessels of the organs, the capillaries, they get stuck there and they cause damage in the organs. Okay? But that's just the beginning, because the immune system has a second wave of attack, and that's by this other part of the immune system called the acquired immune system, where the T cells are instrumental. So the T cells get stimulated by the dendritic cells, okay, in the right host, someone who's got a STAT4 mutation in the T cell, or PTPN22 gene mutation. Their T cells are abnormally reactive to self-antigen. Normally, the immune system should not react to your own DNA, but in people with the right genetic background, it is reactive. This then leads to B cells forming. B cells produce antibodies, okay? And these antibodies bind with double-stranded DNA or DNA that's circulating from these dead cells. And they form immune complexes. And the immune complexes get deposited into tissues and cause damage and inflammation. Okay? The reason I like to show this slide to you, everybody, is that there's many areas that we can actually intervene. For example, we can block toll-like receptors. Okay? Indeed, there are studies of agents that are used to block toll-like receptors. We can do an anti-interferon alpha therapy. Okay? That's in development too. We can knock out T cells, or we can stop the T cells and the dendritic cells from talking to each other. We've mapped out all these pathways, these biological pathways, which allows us to then direct medications. These are called biologic drugs, which target one specific biologic pathway. Okay? So that's all I have with this basic science stuff, but hopefully that's helpful to you. These are all the targets that are in development right now for lupus. So we can knock out B cells with Rituxan, Bliss in April, which is actually Benlysta, the drug that's approved for lupus, that works on that same pathway. Eprotizumab works on CD22, another B-cell marker. Tocilizumab is an IL-6, interleukin-6 marker, and we have drugs for that. There's a whole bunch of new wave of biologics that are being developed. T cells, there's something called regulatory T cells. We can stimulate those guys. Abatacept stops the talking between the dendritic cells and the T cells. So there's a lot of interventions that we can do, and these are all the drugs that are currently being investigated. I'll speak a little bit more about why we haven't cured lupus yet if we have all this knowledge, okay? But I want to also come back to the basics. It's 2015, and how do I treat lupus? If I have a new patient with lupus, what do we do? Firstly, we need to establish the diagnosis. I need to make sure that we're not dealing with some other condition that's masquerading as lupus, okay? Once we do that, the organ systems that are involved need to be really assessed. Heart, lungs, kidneys, everything has to be looked at very carefully. Then we assess for markers of inflammation. And we use appropriate anti-inflammatory therapies that we have available to us. Okay? We have medications for this. But there's also auxiliary treatments that are non-medications, diet, exercise, stress reduction, that'll help with inflammation. We need to make use of everything that we have available to cut down inflammation. And that's the focus of the first few treatment plans that we develop. We use corticosteroids. And everybody hates these drugs. But in 1951, when they were discovered, they were thought to be miracle drugs. Hensch, who discovered it, got a Nobel Prize in 1960 because they changed the game. People with lupus, it was a death sentence. But having steroids changed that. To this date, they're still extremely effective. The problem is, how do we use them? We don't want to overuse them. We need to limit it. We need to have a plan of action to get people off of it, okay? And try to stick to that plan. Doesn't always work. Anti-malarial drugs, Plaquenil, quinacrine, since the 1960s have been used. We use that if you have skin and joint disease and fatigue. Really good. We now know about Plaquenil. It works on those toll-like receptors that I showed you in the previous slide. And then we reserve the immunosuppressive therapies, mycophenolate, Imuran, Cytoxan, for serious and organ-threatening disease. Okay? Lupus treatment requires periodic monitoring, both by the physician and the patient, and that is the key to getting control of this disease. Okay? Vigilant monitoring for other symptoms and untoward consequences of treatment, of the condition itself, also needs to happen. So, I'm going to switch gears and talk to you now about 2015, what's the data with lupus and who's getting it, what's happening to them, and when does the damage really occur. So we have a lot of research to report on. The salient feature of this slide is that in the 1960s, our patients were not doing well. We were losing a lot of patients to this disease. In the 1980s and 90s, we did better. Okay, so we made a difference in survival. But this is the general population. We're still doing poorly compared to the general population. Okay, so we need to do better. This slide shows that the most important or most common cause of death in lupus patients is heart disease. Okay, I don't know if people are aware of this, but it's really something that we need to highlight. The second most common cause is malignancy, which especially lymphomas have been shown to be a higher prevalence in lupus. Infections and kidney disease round out the numbers. Heart disease, I cannot emphasize how important it is to focus on this. 15 to 24-year-olds shouldn't be getting heart attacks. But in lupus, they do. Look at the incidence, the orange bar. In the 35 to 44-year-old range among women, the incidence of heart attacks is 50 times that of the normal population. Okay? So those are astonishing numbers. And we have to be vigilant about this condition and treat it. Work loss remains a huge issue with lupus. And the reasons for work loss, about 33% of patients stop working within 4 years of having a diagnosis. Okay? It's a big deal. Musculoskeletal, neuropsychiatric, and thrombotic events seem to be the main reasons for that. If you have early organ damage, okay, the people in orange did not have early damage. And then we followed them over a period of time, 10 years. We found that people who had early organ damage, the blue curve, survival is not that good. 25% of these patients actually died at the age of 10 years, after 10 years of diagnosis. So early organ damage is important. Within 5 years of having the disease, 33% of patients had organ damage. So these first 4 or 5 years, that's really, really important. That's when our patients are the most vulnerable. That's when accepting that you have a diagnosis, changing the lifestyle that got you to that space, having a team of professionals to work with, having family support to rely on, that's critical. That's where we need to intervene. I showed you data that early intervention, early disease is where we're going to see problems down the road. Okay? So, summarizing the data that I showed you, and I promise you I'll get a little less depressing in my data as we go along. Confirming a timely diagnosis is so important. It's important. Lupus is hard to diagnose, we get it. But being proactive with your healthcare professionals, your primary care physicians to get referrals to rheumatologists, for them to make the diagnosis is important. Treating inflammation without doing harm, that's a challenge. Okay, we haven't figured it out, but we got to try better and do it better. Addressing comorbidities like heart disease, cancer prevention. I skipped that. And infection. Establishing a medical home for patients with lupus and establishing social support structures. Those are the challenges that we have to do better if we're going to get a handle on this disease. I'm now going to switch gears again and talk to you a little bit about the Biologic Revolution. I was a fellow in 1999, and Enbrel, a drug for rheumatoid arthritis, was the first drug on the market at that time, same year. And looking at it, there was a sense of excitement among rheumatologists. Until then, we had nothing other than methotrexate, sulfasalazine, and Plaquenil, horrible, crazy drugs to give our patients, and nobody liked taking them. And these drugs seemed to be amazingly well tolerated. They seemed to really make a difference. And there was hope that now that we know all these pathways, we know these genes, we're going to cure this disease in the next 15 or 20 years. That was the promise of the Biologic Revolution. It's 2015 and we haven't done it. What's the problem? Well, first of all, we have a compliance problem. We have, drugs won't work unless people take them. For whatever reason, it may be not affordable and fear of side effects. The complementary and alternative movement, which I'm a huge fan of, I'm into all those therapies. But the flip side is that it puts the onus on the patient. It's your body. You're doing something. You're not taking the right stuff. Avoid drugs. Those are some of the messages that people are bombarded with. So we have a compliance problem that needs to be dealt with. 1/3 of Canadian patients did not follow up with eye doctors for antimalarials. In the Lumina cohort, large cohort of lupus patients, 50% were not compliant with medication. These are all the drugs. 18 drugs have been tried in lupus and have failed. Okay? It's a who's who list of all the best biologics that we have available to us. Okay? And analyzing these trials, we're like, okay, what happened here? Well, the drug may have been bad and not good and not the right drug for lupus. That could be. The trial design, though, is a big problem. Lupus is such a heterogeneous disease. By that I mean it's so different in different people that lumping everyone together in one clinical trial and trying to make meaningful differences in a short duration of time is tough. That's a tough call for us. Inexperienced investigators all over the world, this movement of drug companies trying to save money and do their investigations all over the world, inexperienced people doing it, not knowing when a patient's flaring. We're also horrible at measuring lupus activity. Someone asked me a question, hey, my SED rate's normal, all my tests are normal, but I still feel like I have active lupus. Yes, you do, but our tests are just not that good. SLEDAI, BILAG, these were designed by men in the 1980s, and we're still using them as markers for disease activity in clinical trials. We need better markers to know when our patients are flaring. We'll get them. We're going to get those interferon signature studies. We're going to get biomarkers. We don't have them today. All these drugs have been tried, and they keep being tried. But we need a new approach here, okay? Something different. And in this context, a group of researchers have come together and formed this network called the LUCIN Network. And it's experienced investigators, and they've studied all the published data to date of everything. Every lupus study has been poured through, and we've tried to figure out what is promising and what is not, okay? And this is an exciting new movement because it allows us to keep going forward. We need to do something, and we are actually, with this LUCIN network, the Lupus Clinical Investigators Network. Firstly, outstanding investigators are identified, and then there's an investment in their education. Then we also give them financial support, and we also involve patients in the trials, okay? Get their input. What's important to you? What do you want to see? And after looking at all of the trials that are available, these are the high priority clinical trials that have been identified. There's a biologic called ustekinumab, or Stelara, which is FDA approved for psoriasis. That's going to be tried soon. ROCK2 inhibitor of KD025 is also going to be tried. Among the complementary and alternative medicine therapies, krill oil and fish oil have been found to be beneficial in animal studies, and they will be tried in humans in real trials. In real studies. Kriya Kirtan meditation, which is a type of yoga meditation which involves chanting for 12 minutes. Amazing studies show that there's a full reversal of the interferon alpha signature genes when this is done. So it needs to be studied. It will be studied. And other small molecules here are going to be studied. We also need to find better biomarkers and do small studies that are meaningful. They may not get a drug approved for FDA, but if I have a study like that, I can go to an insurance company and say, hey, I want to try this for my patient with lupus. So that's going to be the focus of our trials, not these gigantic pharmaceutical-run clinical trials involving hundreds of patients that fail. Okay? So that's where we're going next, and that's our hope. I'm going to talk a little bit, again, switch gears, and talk a little bit about some of the data that I see in the literature that I want to highlight. Vitamin D, there's like a lot of interest. A 2011 article showed that interferon alpha signature was much higher in vitamin D deficient patients in lupus compared to the non-deficient. So it was tried, and this 2015 study shows that there was no difference when you tried it in humans. You replaced vitamin D and you weren't able to replicate it in humans. So there's conflicting data, and as I said in the panel discussion, I think moderate increase in vitamin D, keeping it between 40 and 60 makes sense. What are the long-term effects? We don't know yet. Periodontal disease, gum disease, is seen in high frequency in lupus and should be screened for. Basically means that there's bacteria in the oral cavity that are probably turning on the wrong genes, and vigilance for this is important. Plus, lupus patients get dry mouth a lot, and saliva is antimicrobial, and this should be paid a lot of attention to. Fatigue is the bane of lupus patients, okay? And how do we treat it? I think you heard a lot about exercise, and the question is, am I over-exercising, am I not? And in this particular study, we showed that patients who were exercised did so much better in their fatigue scales. Now, to answer the question of whether lupus patients should actually exercise or is that going to make things worse, this is a great study, came out last year. It showed that patients with lupus were given a 12-week program of moderate exercise. By moderate, I believe they meant 30 to 40 minutes of moderate intensity exercise for about 12 weeks, 3 to 4 times a week. Okay? They stressed these patients by giving them high-intensity workouts, okay? And they found that it didn't flare lupus. The high-intensity workouts in people who were doing regular moderate activity exercise was not bad. High-intensity interval training is now the big mantra for health and wellness. And I think it can work in lupus based on this study, okay? I don't think we're going to do more harm than good by doing those sorts of exercise regimens. In terms of diets, there's tons of books out there. My patients come to me and say, Doc, what do you think of this diet, the paleo diet? It's cured this person's lupus. And I've looked at them, I've read these books because I want to be educated about it and be informed when I give my opinion. And, you know, they are very well written, but very hopeful, optimistic, and the data really isn't there to back them up. Here's a very small, limited data set on patients who are given the low-carb diet, only 45 grams of carb per day, low glycemic index, and that diet did as well as a calorie-restricted diet. My take on diets is that if you have lupus, whatever you've done unto that point that got you to the point where you got lupus is not good for you. Okay? So you need to change it. Be it a paleo diet, be it a low-calorie diet, be it a gluten-free diet, be it what it may. Find the right diet that's good for your body. Work with it, play with it, figure it out. Find something that's sustainable for you. If you've grown up a vegetarian all your life, going on a heavy meat diet is not going to be sustainable for you, maybe. Or it might be. I don't know. You have to try it on an individual basis. The data is mixed. It's not overwhelming, but there are suggestions that these approaches are good. Omega-3s, my favorite topic in previous iterations of this talk. I always tout the fish oils and omega-3s. And this is being studied on a big scale, but I think it makes sense intuitively to take this stuff. Psychological interventions are important. I think the social support in lupus patients is so critical. Identifying those people who are close and dear to you and keeping them really close is important. Psychological interventions in this large systematic review had looked at all the clinical trials. They said that it actually improved the level of depression, improved the overall health status, but just giving psychological interventions and no medications did not decrease disease activity. Okay? So it's part of the solution, not the whole solution. Stress has been associated with lupus from the day it was studied. We know that many studies have shown that stress can exacerbate lupus, but no studies have shown that stress by itself can cause it so far. It's an important thing to work on. And in this modern day, that's the challenge that we face, how to manage stress. Everyone has stress, but how do you manage it? The people who can manage their stress, they're doing well. Those who are not, they're not doing well. So focusing on what stresses you and figuring out solutions to it is a key for managing lupus. This is such an interesting study, I have to cycle it. It's an old study, but it caught my attention, and it will for a long time. High-intensity stressful events, like catastrophic things that happen to families, didn't seem to exacerbate lupus symptoms. But in this study, low-level, daily, chronic stress, the annoying boss and the annoying coworker who kept bugging you, that seemed to make things worse. So how do we prevent lupus and what can we do? Firstly, I think patient and education programs are great. Kudos to Lupus LA, all of you guys, for coming here. Good job. I think this is great, important stuff. Connecting with other people who have the condition, other families, great stuff. Involvement of patients in their own health. You have to do this. Doctors can't do this for you. The paternalistic model, when you went to the doctor and he said, take this medicine, you'll get better, doesn't work anymore. We know that. Doctors don't have the time. They don't have the ability to do that anymore. Patients don't want to hear that anymore. And you have to invest in your own health and be an advocate. You're the best advocate for your own health. Specialist access is so important. Aggressive vigilance, hypertension, hyperglycemia. I'm leading to the heart disease slide that I showed you. I'm going back to that here. You have to focus on these cardiovascular risk factors. Annual EKG, in some people, 2D echoes who are high risk for pulmonary hypertension. Evaluation of any fever. If it's a lupus patient who has a fever, that's urgent. Needs to be evaluated. I talked to you about antiphospholipid antibodies that cause clots, strokes, MIs. Screen for that. If you have lupus, you should be screened periodically for antiphospholipids. And if you are positive, then you need anticoagulation therapy, at least an aspirin. Bone density, we talked about it. Physical modalities, cognitive therapy, and don't forget, diet and exercise, I think, is the key. Don't forget diet and exercise, and don't forget diet and exercise. We have to work on this. Everybody's got to do better. Okay? We know we can. So it takes me to the next part of my talk, which, I'm studying technology and medicine, and this is the part where I look at the data that's out there, and I'm getting hopeful. The oracle of the 20th century, everybody recognizes Steve Jobs, said basically that the biggest innovations in the 21st century will be between the intersection of biology and technology. A new era is beginning. I really see it. I think he was right, as he was right on a lot of things. Personal genomics. Health is becoming really personal. Okay? In the year 2000, we spent 10 years to sequence the human genome. There were institutions all across the world that were involved, and we spent $100 million to sequence one human's full genome. Look at what's happening now. The cost of sequencing the genome. 2015, the cost is here. $1,000 you can get your human genome sequenced. In 5 years, the cost of the postal service for delivering your sample to the lab will be more than sequencing your human genome. You'll be getting it on demand when needed. That's going to change the game. What are your numbers? Does everyone wear a Fitbit? Does everyone look at their numbers? Well, we're not just looking at your own numbers, we're looking at your gut bacteria. And this is a story that's going to be huge. The human body has 10 times more bacterial DNA, 10 times, than human DNA. And what's that DNA doing there? Bacteria in your body. I'm 10 times more bacteria than human. What is it doing? We don't know. We just started studying it. But there's something going on, and we'll find out. This is regulating your genes in a way that we haven't understood. But we're starting to study it. Okay? Here you can get your gut microbiome analyzed. There's companies doing that. You send them a stool sample, and they give you all the DNA of all the bacteria in your gut. And you can see, these are bad bacteria. There's studies showing that Prevotellus species has been identified in early rheumatoid arthritis patients to be much higher in the stool. We'll have studies in lupus soon. There's a growing ecosystem of products out there that everybody is monitoring differently. You can monitor your blood pressure, you should. Cardiovascular disease, lupus, yes, please do. Weight tracking, please do that. There's now cancer screening bras that are being developed. There's Ubiome is a company that measures your stool bacteria DNA. 23andMe shut down by the FDA, but basically was looking at gene markers that are for different diseases to predict your risk. They were overreaching too early. cardio tracking, all these activity trackers, they're all available. Now you can take your body monitoring to an extreme level like this guy. His name is Larry SMARR. He's a computer scientist, and about 10 years ago he started measuring every day his weight, blood, every 3 months, and he started collecting all this data. And he generated within 10 years just 1 billion data points just for himself. And it's there in the cloud, and anybody can see that he had the flu on the X day. What were his numbers like? And try and make correlations between the numbers and what was happening in his life. And that might happen actually sooner than you think for all of us. We have these great devices, the Apple Watch, etc. And big hospital groups, Cedars-Sinai where I work, has started allowing patients to dump all their fitness data into the electronic record. Now, I get all this data from my patients. I don't know what to do with it yet, but it's there. But if I have data from 150 lupus patients and it's sitting there, it's begging to be researched and begging to be looked at, I'm going to look at it. And other places are going to look at it. And we're going to find out some important correlations in this disease. It's easy to get a DNA sample sent out to a lab. Just put some saliva in a tube and ship it, and you get your DNA readout. Your interferon signature is going to be out. You can even analyze what you're eating. There's a company that's developed a device that uses light scanning through a laser, and it'll tell you exactly how much sugar you have, how much gluten you have in it, how much toxins are there in the food. So you can really monitor what you're putting into your body. You can't cheat, but you can monitor it. Wearables and ingestibles and implantables. Does everyone look at this doctor? His patient's down there. He's a surgeon. And where is he looking? Through his Google Glass, he's looking at this screen where he has an enhanced image, where he has a 3D reconstructed image of where the artery is going to go next, so he doesn't have to guess and poke and prod and cut something by mistake. He's getting feedback. So these wearable technologies are here, they're being used, and they're being extremely helpful. Does everyone remember this movie? Does anyone remember it? I know the 14-year-olds don't. Do you remember that? I remember Raquel Welch from the movie. And, they went into the human body, and they had to do something to save everybody. And, they had this little robot that they all fit into. They were miniaturized, and they went in through all the, navigating all these cells. But this was in the 60s, and guess what's going on now? There's something called nanobots, nanorobots that are being developed. Okay, we're pretty close here. This nanorobot can swim by self-generating power. It can have a drug. It can have a camera to find the right cell type that it's programmed to find. And it can put its payload into that particular cell, that dendritic cell that's going crazy and spilling all the interferon alpha. It can identify it and inactivate it. That's the future. It's not, we don't have a study for it or anything yet, but this is where we're headed. We're printing out organs. We can print out different organs. Someone loses their ear in an explosion. You can 3D print, take their own DNA, put it on a biological tissue scaffolding, and implant it. There's no problem of rejection. It's your own organ. It's built out on a scaffolding. This is happening. I mean, this has already happened. My big take on technology, and this is where I think it gets really exciting, is that pretty much everybody can participate now. Okay? There's no reason, whether you're 85 or you're 10 or 11, you can participate in what's going on. When I look at the official map of the internet, I was struck. This looks like an image of the brain that I saw in medical school with all its connections. one neuron here is connecting with something here and getting feedback in real time. We can help each other in ways that we never could. We can connect with people who have similar interests in ways that we could never do. As a doctor, I read a study recently that a physician can probably can remember about 60 clinical trials and their results in their head at any given time. I think Dan Wallace can remember like 1,000 maybe. But, we have computers now like IBM's Watson. Remember Watson that beat Garry Kasparov back in 1997 or something in chess? He was a world chess champion. IBM is now going to release Watson to your smartphone. You can have that sort of data. IBM Watson can analyze over 60 million papers in 1 second and identify different findings. The patient comes to a doctor. He can scan it with his whatever device, his phone, and connect to Watson in the future and get an answer after Watson has looked at 60 million rash papers and analyzed, this rash is this type and this is the treatment based on the best research. So we're going to have some amazing, cool things to work with. We are using social media in very interesting ways, and I'm really keeping a close eye on this because I think social media humanizes this technological aspect and actually makes it useful to us. Okay, by searching, people saying I'm feeling sick or what's the treatment for the flu, and Google keeping track of the location, you can predict where the flu has hit next. Now, you can use Twitter when you tweet that, oh my God, I'm feeling horrible, I feel so sick, and using those catchphrases, you can develop a map of where the flu is headed. You can certainly map out all the social contacts, all the Twitter followers of this person, and all the people who are in that geographical location. You can actually predict who's going to get it and where. So that's coming down, that sort of research. So I really believe in this social networking. I use it all the time. I'm learning to use it. This wasn't intuitive for me. But I now get a lot of information from social network. There's a lot of noise, so filtering out the noise is important. But I can connect with colleagues around the world who've seen things that I may not have seen. They're excited by a paper, people in my social network. I'm like, oh, wow, okay, I'm learning about this. This is great. I don't have to look at hundreds of papers and read like hundreds of journals on a daily basis. I mean, I want to sleep. But I think social networking is going to be the way of the future. It's going to be the digital age's answer to this sort of community support. You're going to all find your own community, your own niche of people who are like you and that you want to connect with and are feeding you good information. So I would really like all of you to start thinking about that. And if you do, then I'd like you to also like this talk on social media. And we'll put it up. So this is the end of my talk, but we're going to have all of this online. So if you Google it, you'll get it. We'll have an audio of my presentation. All these slides will be there so you guys can look it up. Share it with friends, whoever needs to look at it. Okay? I'm sorry? On the Twitter feed. Maybe. Yes, we should. Why not?
We have lunch in about 8 minutes, and I want to let him finish.
I'm done.
You're done?
Yeah.
Okay, good job. I'm going to ask that you write your question on these index cards. We don't have time to do live question answer because we have to go to lunch, but we will get them answered from you, and we will email them. Maybe we could take, if you are done, we could take maybe 1 or 2 questions now.
Yeah, I'm done. Yes.
Here's one. If anyone has questions that you've already written, we'll walk up and down also.
Well, the question is, do I have any information about the overuse of antibacterial soaps and gels as a contributor to lupus? I personally don't. I mean, this is a worthy question of research. I think it's important to think about it, especially because I presented some data saying how important the human microbiome is. And if we're affecting it with antibacterial products, then potentially it could be important. I don't know the studies. I have to consult Watson and get back to you. Again, what are the additional environmental factors that may trigger the immune system? Environmental toxins, absolutely. There's a lot of studies that are looking at it. What are the specific toxins in the environment? I don't have them at the top of my head. I do know that in the studies we have sun exposure. Infections can be a trigger for lupus. Trauma can be a trigger for lupus. Post-surgery, which I put under trauma, is also a trigger for lupus. And then a bunch of environmental toxins. I think there's some data on mercury exposure for sure. I don't have the statistics in my head. These are all great questions. I do think there's something to it. Can lupus cause male baldness? Can it be stopped? Yes, lupus can cause loss of hair. Absolutely, any chronic disease honestly can affect hair growth because it's a protein that keeps accumulating, and if there's any problem with nutrition for any period of time, people can lose hair. There's two types of hair loss. One is non-inflammatory alopecia, which is when the hair follicles just fall off, but the follicle itself is not damaged, and there can be reversal of that type. But in lupus, we actually see inflammatory hair loss, where there's inflammation of the scalp with total destruction of the hair follicle. And in those situations, it's not reversible. But once that condition is stabilized, then hair transplants are an option. Fevers, explain more. Well, low-level fevers can be part of active lupus. But high-level fevers, high-grade fevers, which I characterize as over 101, indicate some sort of a more significant infection and needs to be evaluated carefully in a lupus patient because you may be immunosuppressed and a small, simple cold can progress to a pneumonia before you know it. And those are the kinds of fevers that I'm talking about. Low-grade fevers, 99, 99.2, 99.4 on a daily and chronic basis means that lupus could be active, and the treatment is not antibiotics or fighting off infections with drugs, but to treat the lupus, to control that type of fever. Can lupus cause lymphoma? Cause is a tough word in medicine. To prove that something causes something else, you need to be able to replicate it in multiple studies and show time after time in different populations. So the data shows that lymphoma is definitely seen at a higher level in lupus, and the cause and effect has not been established. It could be that, for example, it could be that the same environmental toxin that caused lupus has also caused lymphoma, or it could be that the same infection, for example, Epstein-Barr virus, has caused lymphoma and has also caused lupus. So cause and effect is extremely hard to prove, but association is certainly present in the studies. Are there any new drugs on the horizon that will treat lupus and not compromise the immune system? Great question. I showed you the data that we have available so far. There are certainly some drugs that are more promising than others in this regard. For example, there's a type of T cell called T regulatory cell. And there's drugs, and these cells, what do? They're T cells, but they actually stop the immune system from overacting. And mice that were given these T regulatory cells as infusions actually did better, and their lupus got under control. Now, in humans, there's drugs that are being develop that actually stimulate the production of T regulatory cells. So that might be one approach where you're improving something good and not necessarily suppressing the immune system. I think, yes, there's a lot of medications in development out there that might not suppress the immune system like the traditional biologics that we have now. It's possible. It's happening. I don't have anything yet.
We're going to do 2 last questions. These are amazing questions. I'm picking the ones that I think have shorter answers just to try to get as many. But we will get these answered for you.
Having kids with lupus, what is the risk on the child? Yeah, great question. I think I told you that genes account for 25% of the causality of lupus. So it's generally not transmitted from mother to daughter, but it runs in families. So these genes that I showed you, what we understand of lupus is that it's multifactorial, multi-gene. So it's not just one gene defect that's important. Many genes sometimes need to interact again with each other to cause lupus. And more importantly, they need to have the right environmental trigger. So mother-to-daughter transmission is not 100%, certainly. It's closer to, maybe 10-15% even. So, and it's probably even less than that if, depending on how much of a genetic component is present in the mother. So, for example, the genetic variants of lupus are much more important in pediatric lupus. That's where we see the genes as being really important. So, if you got lupus when you were a kid, more likely than not, you got the genes were really important in causing your lupus.
Can I hand you one more question?
What do I mean by medical home? Yeah, great question. So medical home means that a place, a repository where all of your medical data resides, where your a medical team of professionals, including your physical therapist, your primary care provider, your rheumatologist, your well-wishers have access to this information. And this is a concept that is being advocated actually in the new healthcare law, where patients with chronic diseases are given medical homes, and the primary care practices that take care of these sorts of patients are given incentives to be able to do this. So it's an evolving concept, but clearly I think that in a chronic condition like lupus, collaboration and being able to access one's data in real time, to use it to make good decisions is the way to go. And a medical home this is the concept of the medical home. Right?
Thank you so much. That's
Welcome.
amazing.
Thank you.
We are now going to break for lunch. You have 50 minutes, 50. So it would be great if you could be back in your chairs by 12:50, please. And enjoy your lunch. It's out in the lobby. If you have more questions, please hand in your index cards at the check-in table.